Hello, my name is Sue Lorbach, and I'm currently the Executive Director for the KVC Institute for Health Systems Innovation, powered by KVC Health Systems. I'm also the developer of the Consultation and Information Sharing Framework and co-developer of the Red Team process. Today, I've been asked to give a brief description of the Red Team process and the Consultation and Information Sharing Framework in the context of child welfare and child protective services. Both the Red Team process and the framework may be utilized in many other service contexts and in both the public and private social sectors. Red Teams represent organizational infrastructure for collaborative practice. So building within the existing system new roads and bridges, if you will, around more collaborative practice, offering a structured group decision-making process to facilitate critically thinking through child maltreatment referrals and the information received by a local child protective service agency. RED is an acronym that stands for Review All Available Information, Evaluate that information to specific criteria, generally statutory descriptions of requirements for valid reports of child abuse and/or neglect, and to direct a decision. And a decision is usually around whether to screen in or evaluate in or out the referral and subsequent service delivery to families. The Red Team process promotes critical thinking, transparency of decision-making, shared risk-taking, and accountability regarding the initial response to a referral concerning child maltreatment. The Red Team was originally developed in 1999 in Olmsted County, Minnesota, which is in the southeastern part of the state, and has been implemented both nationally and internationally in multiple jurisdictions in both the public and private sectors. Participants in the Red Team process represent multiple disciplines. For example, social workers, lawyers, health nurses, may also include community providers, elders. There's a lot of choice in terms of participant inclusion. Typically, as would be the case in any group process, the optimal group size would be approximately 6 to 8 participants making up the group, and there's space available for silent process observers, such as new staff learning the process, or those who may want a chance to observe in their process of thinking through implementation. The Red Team is a facilitated process, and information is shared through the Consultation and Information Sharing Framework. So generally the room would be set up with a facilitator in front of the room, standing at a whiteboard, smartboard, flip charts, and the rest of the group would be in front, so that everyone is looking at a collective task, and that collective task is sharing as much information and getting as clear as possible on what is being written and facilitated onto the whiteboard or flip charts. The Consultation and Information Sharing Framework represents that basic structure supporting critical thinking, collaborative practice, comprehensive and holistic assessment and inclusion. The framework has been utilized across disciplines as well and functionally organizes all available information, views, and perspectives in service to ongoing assessment, planning, and decision-making. I developed the Consultation and Information Sharing Framework in 1999, and it was fully implemented in Olmsted County Child and Family Services and Family Service Rochester, which is a private nonprofit organization in Minnesota in the year 2000. The framework has been institutionalized and remains currently in use. The framework has additionally been implemented in multiple states across the United States and in a number of countries, authorities, and provinces internationally. One or more Red Teams would be facilitated on a daily basis, and the number of operational Red Teams is variable and is really dependent on the size of the jurisdiction and the number of referrals received. There are specific roles within the process. The role of the facilitator, who guides us through the use of the framework, so is actually facilitating the information from those at the table and through the electronic record systems onto the whiteboard or flip chart. There's a participant who presents the referral information, generally reading through that information or report. There's a participant who uses a laptop computer to share any of that known agency history with the family within the electronic records, often known as the SACWA system. There's a participant who documents the framework information either by hand or computer. And there's a participant who may transcribe the genogram. Because the genogram is a pictorial representation of the family that is written onto the whiteboard or flip charts, depending on the availability of particular software, sometimes it's most practical to take a picture or to simply redraw the genogram to be entered electronically in another way. All participants are actively involved in the decision-making process. The primary decision that is made is whether the information described in the referral meets the criteria as an accepted referral or report of child abuse and/or neglect, and whether to screen or evaluate in or out, and attach a determined response time, and whether there is a particular way to approach the family if evaluated in, either through an investigation or another response that may be specific to systems that are organized around differential response. Decisions are reached through consensus, so the way that most practically would be discussed would be through the facilitator turning to participants who may have dissenting views. So if one participant is really coming to a conclusion of a value of screening in, the facilitator would ask that participant to talk through what information are they tuning into that assists them in arriving to that sort of view. And likewise, if another participant is really leaning towards screening out, what information are they tuning into that leads them to that conclusion. In that way, the entire group benefits from a full discussion of the differences in views to arrive at a consensus around a decision to evaluate in or out. There is a gray area that is utilized very heavily in the Red Team process, and that is a place to deposit the speculative or incomplete information or follow-up questions that people have. A lot of time is generally taken around speculating what a piece of information might mean, and that is often an entry point for confirmation bias and other inherent biases to come into play. So in an effort to guard against those biases, utilizing the gray area and ensuring that all views are presented assists in challenging and managing that possibility. It's important to elicit as much detail and specificity as possible, both through the presenting concerns and any known protective behaviors and/or environments. This detail enables a more confident decision. That gray area within the framework that is holding those follow-up questions can also inform and provide clear direction should the referral be evaluated in and an investigation or assessment initiated. So that information and those follow-up questions and other gray area items actually inform the practitioner who may be working with the family subsequent to a screened in or evaluated in referral. Some of those examples for follow-up questions might be information that comes in that is sort of speculative around the presence of the possibility of the dynamics of domestic violence, intimate partner violence, behaviors or questions that may indicate drug use or a trauma history, and or questions leading to clarification of family or extended family. When thinking about planning for implementation, there are a number of considerations. One consideration will be how many red teams will be operational per day. If there are multiple red teams that need to be in play, are you going to phase in or start multiple teams all at once? There's a lot of choice around who participates. Are they all going to be internal to the organizational staff? Are there going to be community providers, elders, or others who may be present? What decisions are going to be made within the red team? Generally, the evaluator screen in or out would be the primary decision, any attached response time, and any particular approach. In jurisdictions where there may be formal responses for evaluate out or screen out referrals, that may be another decision that would be easily added to the red team process. The space that would be available, generally an allocated space where everyone knows they can count on being on time too, is favorable. Within that space, it would be important to have the whiteboard, the flip charts, the smart boards, access to a laptop computer, any particular decision support tools that may be in play in the jurisdiction, any other prompts that would be helpful, markers for the whiteboards, erasers. There would be decisions around workload allocation. Generally, as you're having participation by those across the organization, there may need to be worked out some sort of rotation schedule or backup if people are ill or on vacation. What kind of prep or orientation for staff on an ongoing basis, sort of an ongoing onboarding process as well. Practice improvement groups provide a very nice opportunity for feedback loops or some other forum in which one can look at the challenges, the benefits, ask the questions about where we are, and implement any kinds of continuous quality improvement processes. There is a fidelity tool specific to the red team that is available. I developed it in partnership with the Children's Research Center and the Center for the Study of Social Policy, and it has been tested in a large jurisdiction on the East Coast. For more information, technical assistance, training on the red team process, please contact the Northern California Training Academy. Thank you.